Facial nerve injury, overview and management. Anatomy of the facial nerve. The facial nerve, cranial nerve cephalin, is a mixed nerve with motor, sensory, and parasympathetic components. It innervates motor, muscles of facial expression, stapedius, posterior belly of the digastric, and stylohyoid muscles. Sensory, taste sensation from the anterior two-thirds of the tongue. Parasympathetic, lacrimal and salivary glands, submandibular and sublingual. The nerve exits the brainstem at the pontomedullary junction, traverses the temporal bone through the internal auditory canal and the facial canal, and exits the skull at the stylomastoid foramen. Causes of facial nerve injury. 1. Trauma. Temporal bone fractures, longitudinal or transverse, surgical trauma, e.g., parodectomy, mastoidectomy, blunt or penetrating injuries to the face. 2. Infections. Bell's palsy, idiopathic, linked to viral reactivation such as HSV, Ramsay-Hunt syndrome, reactivation of varicella zoster virus. 3. Tumors. Acoustic neuroma, vestibular schwannoma, parotid gland tumors, facial nerve schwannoma. 4. Iatrogenic causes during head and neck surgeries, including otologic and parotid surgeries. 5. Neurological disorders, stroke, multiple sclerosis. 6. Congenital conditions, Moebius syndrome. Birth trauma. Clinical features of facial nerve injury. 1. Motor dysfunction, incomplete or complete facial paralysis, loss of facial symmetry, drooping of the mouth, and inability to close the eye on the affected side. 2. Sensory and parasympathetic dysfunction, loss of taste sensation from the anterior two-thirds of the tongue, dry eye or mouth due to impaired glandular function, hyperacusis due to stapedius muscle paralysis. 3. Associated symptoms, pain, particularly in Ramsay-Hunt syndrome, vesicular rash in Ramsay-Hunt syndrome, hearing loss if the nerve injury is associated with the inner ear. Diagnosis. 1. Clinical assessment, detailed history of trauma, infection, or surgery, physical examination for facial asymmetry, muscle strength, House-Brackman scale, and sensory deficits. 2. Imaging studies, CT scan for bony trauma or fractures, MRI for soft tissue lesions, tumors, or demyelinating diseases. 3. Electrophysiological studies, electromyography EMG to assess nerve integrity and muscle response, nerve conduction studies NCS for functional evaluation. Management of facial nerve injury. 1. Medical management. Corticosteroids, high-dose prednisolone is the mainstay for Bell's palsy. Antivirals, acyclovir or valacyclovir, especially for Ramsay-Hunt syndrome. Pain management, NSAIDs or opioids for acute pain. Eye care, artificial tears and lubricating ointments to prevent corneal exposure keratitis, temporary eyelid taping or protective glasses. 2. Surgical management, decompression surgery, indicated for facial nerve compression, e.g. due to fractures or tumors. Nerve grafting or anastomosis, cross-facial nerve graft or hypoglossal facial nerve anastomosis in cases of severe or permanent nerve damage. Facial reanimation surgery, dynamic techniques, e.g. gracilis muscle-free flap, static techniques, e.g. fascial slings or eyelid weights. 3. Rehabilitation, physiotherapy, facial muscle exercises to improve tone and prevent atrophy, biofeedback therapy for targeted muscle control, botulinum toxin to manage synkinesis, involuntary facial movements, or hypertonicity. Prognosis, Bell's palsy, 70 to 85% recover spontaneously within 3 to 6 months. Traumatic injuries, recovery depends on the extent of damage and timely intervention. Ramsay-Hunt syndrome, recovery rates are lower, 50 to 60%, particularly if treatment is delayed. Complications, permanent facial asymmetry or paralysis, synkinesis, involuntary muscle movements, dry eye complications such as corneal ulcers, psychological distress due to facial disfigurement. Early diagnosis and a multidisciplinary approach are key to optimizing recovery in facial nerve injuries.